So yeah, thanks everybody for joining us this afternoon. Great little turn up for this lecture. I'll also be recording this for those people that haven't been able to make it at this time of the afternoon, and pass it on to your colleagues and undergraduate students. As I said, thanks for joining us. This is an introduction to clinical Pilates. How does it fit? Where does it fit in the physiotherapy landscape? It's on the back of the job show in New South Wales last weekend, but at the same time, similar to lectures we gave for many, many years prior to COVID through the APA state branches, where we'd present this to students when I was in those states. So I'm hoping to pick that all up again now that we've got that behind us. And as we know these days, we have many more universities teaching physiotherapy, so it's getting guys ready for the profession. All right, let's get my screen running. So, as we know, physiotherapy and clinical Pilates have sort of been firmly linked now for many years. In fact, we presented clinical Pilates to the physio profession some 34 years ago. It was the first time Pilates had been presented in Australia. We started the first clinic in Australia in the late 80s, Paran Sports Medicine Centre. Evolved it from Pilates into the clinical Pilates, as we were working with sports people, and kept it just for the physiotherapy profession, allowing us to evolve this as a treatment tool. It has become a mainstay of practice, and you'll find a lot of you guys going into the profession will see that Pilates, particularly clinical Pilates, will be a prerequisite. So where does it fit in? As I said, we started this some 34 years ago. We were linking into the stability research that was starting then. That has moved on a lot. We've been involved in a lot of research and still involved in a lot of research. And as I said, we've kept clinical Pilates just for the physiotherapy profession to push it at the edge. Exercise goes with everything these days. There's no doubt or no question that every form of medical management includes exercise. Cancer and exercise, cardiorespiratory and exercise, of course, neuro, musculoskeletal, even mental health. You need to exercise. So this idea of exercising, but also incorporating exercise with treatment to provide an outcome that keeps people moving and functioning. We're seeing big correlations between musculoskeletal, sports, neuro, aged care, going from one extreme to the other. One thing we all do need is function. The other big thing, of course, is research. There's been a lot of research in the last 20, 30 years. Unfortunately, a lot of that research isn't being translated into practice. And this is the big challenge we have now, facing how do we work with translational research at the coalface. Things have changed. Yes, I remember those days. And of course, the days of cocaine tooth drops, we must miss those. But there's a lot of things that haven't changed. And this is the problematic thing, that no matter how much evidence, it's not being put through. The APA produced an excellent document last year called The Value of Physiotherapy in Australia. So it's a template for where we as a profession now need to go to demonstrate our value in the healthcare profession. We have enormous value that is still not being recognised. The structure is changing. It's changing even more. Better value healthcare. More and more money is being put into health, but the value is not necessarily being demonstrated. We are running out of money. In fact, this has been demonstrated with COVID, how much money has been spent, and we now have to make up. Knees, hip arthroscopies. Now, the evidence shows the opposite, but we're still seeing that evidence is not being put into practice by the large volume of low value or contraindicated surgery still being performed. Costs are going up and up, and the outcomes aren't correlating. The idea of keeping people out of hospital, great idea, but the funding stream actually isn't there. And this is one of the processes that we are advocating for, to say more money into the primary sector will save huge amounts on substituting hospital admissions. So we're going to be very important over the next decade, incredibly important as a profession. And one of the focuses we're looking at is the high cost, the chronic complex patients. These are the ones, the repeat offenders, the frequent flyers, in and out of hospital, having revisions on joints, surgeries, test after test after test. There can be a simple model for many of these people that can short circuit that expensive process. You might even get paid better as physios. And this is real. It's happening now. Insurers are starting to talk about this. You know, the average joint surgery, knee replacement, hip replacement, etc., $30,000 to $35,000. Now, if you can stop that procedure, provide the outcome, and had you not intervened, it would have gone ahead, there's $35,000 saving. They're now talking, some of the insurers will pay you $12,000 to $15,000 for a good outcome for Jack's knee. There it is. And why? Australian Institute of Health and Welfare have just produced this document. Looking back, and this was pre-COVID, of all the major problems, you know, dental caries, that surprised me, being one of the highest. But the next three, physio, mental health, coronary heart disease. Of the big six, $11.5 billion falls right in our lap. Mental health gets much more money, huge amounts of money going into mental health. When you've got sort of 5 times the cost against osteoarthritis, falls, and musculoskeletal problems, that's not getting the funding. So there's a bit of a mismatch here. What are we going to do about it? We also heard about Pilates some time ago, and there was look at health insurance reforms, and there has been for quite some time. But back in 2017, there was a drive to eliminate low-value efficient healthcare, try and keep people out of hospitals. At the same time, strengthen and look after consumers so they're getting better bang for their buck. And it was also looking to say, you know, are there things that we shouldn't be paying for? Alexander Bowen Pilates got put in the mix there, shiatsu, yoga, tai chi. You know, these natural therapies were not going to be covered by insurers anymore. So looking at new funding methodologies, I don't know what's happened to that, but this was meant to start on April 1st, interesting day, 2019, on the basis that Pilates, amongst all these others, had no evidence. We spoke at length with the government and said there is evidence. We've published evidence with this with the Australian Defence Force, Melbourne University, Otago University, Cardiff University, worked with Australian Institute of Sport, English Institute of Sport. They said there is a large volume of research evidence published that states the efficacy of Pilates. And this is where clinical exercise suddenly became a name to replace the name Clinical Pilates, which is not what physios do. Physios don't do clinical exercise. That's what exercise physiologists do. So it lasted 6 days. This term clinical exercise really only had a 6-day lifespan because on April 7th, the government announced a full review. Let's hope it was based by the fact we produced some evidence and research to state they were not right. And there's a body of evidence to prevent certain musculoskeletal disease conditions and the exacerbation of asthma. Well, yep, there we go. But Pilates, particularly, there's a body of evidence that they do prevent problems. $2 million review was announced to look at this. It was called the Natural Therapies Review, NETREAP, looking at the evidence again to say, okay, what have we missed? We said you've missed a lot, and we're still waiting for the outcome of that. Unfortunately, there are no physios involved in this Pilates review, so we're still waiting to see where that goes. But Clinical Pilates is the name, no longer clinical exercise, although we still see it being used. So where is the future? The future is going to be looking at physios, practitioners who get better outcomes, measure their outcomes and say, yes, we can provide this and measure. Take the numbers. Don't waste money. Don't waste time, and don't over-test. And we see this with a lot of over-testing, radiology, a lot of time wasted going around and around the system, and a lot of confusion. Way too much confusion out there where people don't know what's going on, and they're saying, we need to go to the next person, and this word complex keeps getting used. We have to simplify this. And one of the big things is solving problems, not just treating pain. Get to the source of the problem. COVID has highlighted this as well. Another big problem we've got, waiting lists. We have the longest elective waiting lists in the world. Australia has the highest elective surgery waiting list of 193 United Nations countries. Came out of COVID Surge Collaborative and Birmingham University. Australia ranked #1 in the world for elective surgeries. Why? Victoria alone has some getting close now to 100,000 people on the waiting lists. And if we look at each state, we're looking at a lot of people sitting on waiting lists. The second largest waiting list surgery are orthopedics. How many of those don't need doing? And we know joint replacements, 30 to 40% of knees alone are not necessary. This is a lot of money. So is there a solution? And this is where we've coined this term MBCT, Movement-Based Classification and Treatment. So the treatment is a big focus and incorporating exercise, movement, but not just generic movement, a classifying system. We'll talk about that versus your structure-based classification and treatment. Now, we know from what we see in the literature, and we know the lifetime of treatment, that it's 4 to 6 weeks for treating a structure. You sprain an ankle, tear a muscle, do a ligament, bit of damage. We know what the time frame is in the acute, subacute phase for those things to heal. So most of our structural healing time will occur within that 6 to 12 week period, 15 weeks. But if you've got a structure which is still causing problems, supposedly at a year, 2 years, 5 years, we can't really base our management on a structure any longer. The evidence will tell us that till we're blue in the face. We know that we can't look at a radiology and say that structure is causing the problem. One study I like, Herzog, same patient with went to 10 different MRI units with low back pain. So 10 reports with 67 variations of that same patient with the same problem. We cannot rely on radiology to identify structure. We know that shoulder tests, how many shoulder tests are there for so-called structure? How many are valid? Not many. What's his name? O'Brien wants his name removed from O'Brien's test for slap lesions because Chad Cook took him to task on it and said, you are not identifying structure with these tests. We can still use them as function, but certainly we have to move beyond structure, particularly when structural management has failed. We move into movement. So with clinical Pilates, it's a treatment tool. So of course, in the acute phase, we micromanage. We're pathoanatomy based. As I said, it's a structure, it's a tear, it's a ligament, an ATFL, it's gone blue and swollen and popped, and we know how to manage that. We know treating the tissue 6 to 12 weeks should be doing pretty well. But there's the point, this comes along. You're getting chronicity. Einstein's definition of insanity is treating the same thing over and over and expecting a different outcome. We have to have something else we can employ. And this is where you're going to function rather than structure and systems-based management. It's macro. Look at the whole system, not just the site. It's the big picture. Stand back. This thing of, you've even heard it now, at the undergraduate level, patient comes in and says, I've got a sore hip, but I've also got a sore glute on that side and a sore knee, my ankle's a bit sore, my shoulder's sore, my neck's sore. How many times have we heard this from patients that I've got all my problems on the one side? This is one of the elephants in the room. Somewhere between pathoanatomy, we have to address this problem and look at biopsychosocial. I have yet to see a good RCT on biopsychosocial, but if someone's got one, please send it to me. But we can do this. We can decomplicate the biopsychosocial. We're going to have to, because there's a new name that's come out for biopsychosocial called the socio-psycho-biomedical. The medical felt left out, but we have to see that this can be managed with a system. Yes, we're still going to have to manage pathoanatomy at some point, but we get away from that and we can treat the bio and say, here are the things most likely to be involved: inclusion, exclusion, differential diagnosis. You say to people, good, I'm not going to worry about the structure. That'll have a big effect on their psycho. And you want to get them back to function, quick, smart. That was biopsychosocial for dummies. So Pilates, where does it come in? Joseph Pilates, he came from the culture physique era of the turn of the 20th century. Exercise. There was a lot of exercise promoted around that time. A bit like Carl Benz, he had a pretty good idea at that time and thought, maybe we can make a motor car. Of course, it's moved on there. I wouldn't mind a SLR McLaren Mercedes. Haven't got one yet. But clinical Pilates started to evolve. We were looking at movement in a controlled environment. Rather than open kinetic chain, give them a task to do. Rather than consciously trying to think of muscle activity, give the muscle a task to do. We found this was much more effective. Also looking at ultrasound, getting people on ultrasound machines. They have gotten a lot smaller since then. And looking at muscle activity without conscious cortical effort, working at the subcortical level. I've lost my sound. But poor old Pilates. It's become very popular in gyms, but it's not safe. You can injure yourself, and you can see there he's strong, but he doesn't have good control. A big issue. Oh, here we go again. The music's there in the background. And we've lost him. One notice there too of being close to your patient. But this is this thing. For many years, Trudy Rebeck was talking about this 20 years ago. Exercise programs are effective in reducing disability. This specific exercise programs may be more effective. And again, getting away from generic exercises. And this one thing that does annoy me, we're still seeing protocols of exercises, generic exercises, as if we can give the same exercise to a group of disparate people and expect the same outcome. You can't. Everybody is different. And the thing that this difference or this specificity is their directional load, their response to directional load. In his case, if he likes flexion, well, they've just been loaded into flexion. It might actually do him some good, but if he doesn't tolerate directional load into flexion, you're going to have a problem. We could include a disc bulge in that clinical diagnosis. But this is, again, one big thing we're finding is this response to directional load. We've now studied it, we've done integrated reliability on it, and it's there. We can look for muscle-specific approaches. There's many been done, but they've never reached this level of evidence. They've never reached level 1 evidence. And we find every time we dig into looking at these things, direction comes back at us. This direction model comes back at us, not structure. How do we use this to our own effect? So it's this. Observation leading to intervention. Sure, as I said before, if you tear an ACFL, it swells up, it bruises. And we know what the intervention is. Get it moving, it'll settle down. Bit of ice, compression, movement. Yep, great. But there's a point at which, as I said, that's no longer working. This guy's still having problems with his ankle 2 years later. What are we going to find here to translate to provide an intervention? And this is where it comes down to. The observation being, you've got a flat tire. The intervention, I'm going to pump it up. Makes sense. It looks pretty good, but the next morning it's gone flat again. So you pump it up, you flatten it, pump it up. And we get this observation intervention system going on, but no one actually has figured out, why is this going flat? Thinking about differential diagnosis, mate, you've got a nail in the tire, get that out, and then your intervention will work. Can we make it any simpler? As opposed to just doing the same thing over. We see people stretching and stretching and stretching and wonder why they get recurrences of injuries, for one. Our old mate transversus is directional. Out of all the work done on it, we know now that it has been disbanded, but it didn't do much in neutral. Everyone got this idea of core stability. It's a whole industry in itself. Strengthen your core, to the chagrin of a lot of women's health physios. But in fact, Donna Urquhart's study that she did back some nearly 20 years ago, looking at rotation, EMGs on a chap in a chair, to rotate him contralaterally, and only the upper fibers of one segment on the opposite side fired. The assumption was the middle and lower on the same side as the rotation would fire. Rotate ipsilaterally, and the middle and lower fibers fire, but not the upper. the assumption being the upper fibrous fight on the other side. So we're seeing this regional independence, and we're seeing it's directional. Transversus is a rotation muscle. It is not a corset. And this is where Sue Morris, Gary Allison in WA, Gary Allison, Professor of Physio at Curtin University, found that training TA was not a symmetrical movement, and it wasn't independent of perturbation with arms. So moving one arm, the load transfers to the other side. It didn't work on both sides. So this idea of training a corset didn't hold up under scrutiny. In fact, we saw more problems. People working these cores and they couldn't actually move. Their movement was compromised because the system said, I don't do that. Going one step further, we're finding that this idea of using load, which is what happens as you move asymmetrically, that it was the opposite side. So again, we had a directional specific diagonal pattern, again, Sue Morris's study, and that was the end of transversus there. But the thing that's been missed is the fact that this is a movement muscle and it responds to movement and load direction. So we start looking at athletes. How does this work with an athlete? Let's go and get Shane Watson. High-level cricketer, been around for a long time. Had a lot of injuries. This was in the paper a while back. He's got shoulder problems, back problems, side problems, groin problems, and a happy birthday hamstring and calf. Is there a pattern there? It's all on his right side. And I've confirmed this with the cricket physios. Yep, there it is. Now, has he got 1, 2, 3, 4, 5, 6, 7 things going on, or is there a pattern? And again, if he went and had another hamstring injury, which he's had, guess which side? Same side as every other. We've worked with Premier League teams, AFL clubs, Olympic athletes. This pattern of one-sidedness is an 80% factor. Major teams going from the captain down, one-sided problems. We've pulled them out, we're looking at them. How do we use this? Because it is an elephant in the room. Now, what's that? It's a bit confusing, a bit weird, coming from the theatre world, but you stand back. Too much detail. Don't get distracted by all the detail. Blur your eyes, take out some colour. You've got Sigmund Freud. And this is the problem. We don't see the big picture. We focus in on a structure, pathoanatomy, and we miss the fact that there's a lot more going on there that'll tell us whether that thing we think we're treating is actually relevant. We get distracted by too much detail. So what is different about clinical Pilates? How does this apply to what we're doing? And this is where function comes into it. Looking at function and also being able to provide treatment that is not homogenous, that is not protocol driven, that is not a recipe of one size will fit all. How do we subgroup and provide suitable heterogeneous treatment? So we started looking at research on this. One of our colleagues through Singapore General Hospital, Edwin Lim, was looking at this for his PhD and found there that Pilates was better than doing nothing. Like transversus, it was better than doing nothing. But when you compared exercise with exercise, your p-values there show it. Not great. The studies at that point, some 10, 11 years ago, weren't terrific and said, careful, let's do some RCTs. So we did. Did an RCT through Melbourne University, comparing apples with apples. So looking at general exercise versus clinical Pilates, which was directionally specific exercise for chronic low back pain. So no acutes, no subacutes, only chronics. This was carried out on only chronics and only delivered by physios. We had a 14-year average, so we matched the groups. There was a bit of interest in this, how chronic is chronic, but we said, no, let's go ahead. And it was a 6-week program to see, right, can we make a change within 6 weeks? Maybe 14 years is too chronic, but 3 and 6 month follow-ups. The general exercise group were given the multi-directional, every direction, protocol type thing. Everybody got the same 6 weeks, twice a week for 6 weeks. Sit them on a bike, put them on a ball, 4-point kneel exercises, rotation, the standard things that are still being given out through physiotherapy. The treatment group, they were subgrouped on this directional preference model. So they were given one side, one direction. You got flexion, extension, neutral, left or right. So it ended up being one direction, be it flexion or extension, and one side, be it left or right. Like with any research, this wasn't perfect. We had a fifth group in there, the neutral, which we determined later, post-hoc analysis, was a non-responder group, but anyway. Same thing, they were given exercises on equipment and twice a week for 6 weeks. And exercises such as this, where you've got movement in a controlled environment, so you've got the afferent input going in, and this we call an extension biased exercise. The system is an extension. You're moving, but maintaining extension. This exercise is a one-sided extension exercise. So that's a left extension. So we're not going to do it both sides. The problem here is the moving side, the left. Your weight bearing supporting on the good side, we've found that is valid. So that's a left extension biased exercise. This exercise is flexion. This exercise, for example, is also flexion. So you're not going to see these exercises on the same program. You'll see them on different programs specific to that patient's tolerance, to be it flexion, extension, or one-sided problems. So at 6 weeks, we found both groups improved, P001, that's good. So even doing just any exercise for somebody is better than doing nothing. We had a low dropout rate, that was great. The general exercise group improved 29%, that was significant. The clinical Pilates group, 46%. So again, a measurable difference, both significant. And on baseline adjusting, there was still a recordable difference between those two groups at the P07 level, which if you take out that fifth group, the neutral group, it did bring it down below P05 nicely. But that's another study if somebody wants to help us take it up. No, we've got another one going actually in Singapore, and another PhD currently being done looking at this in more detail. So exercise is effective. So where does this directional thing come into it? It's what we call a matched bias. This bias being, you'll hear the term bias being the one direction, one side model. Study we did with Liverpool Football Club, we've been working with other EPL teams on this, but a measurement, in this case, valid, tool, easy. How high can you jump? And time in the air is a measurement, the longer in the air, the better. And on this one, we're seeing on the left-hand side, they can jump this high, on the right-hand side, only to here. So the right side being the problem. The player was then given a match bias program and then reassessed and found, yes, we can improve on the right side and a bit of improvement on the good side. Then we had permission, go and do unmatched exercise. So go and do the wrong things on purpose. And performance deteriorated markedly. They said, you can only do that if you can promise you can fix them again. We said, I'm sure we can. Go and do the right thing again, and we found we had a recordable improvement. Now, the interesting thing with this is all happening within session, within subject. Subjects are their own control, and there are no other variables. This is not 2, 4, 6 weeks. We have a post hoc analysis showing the time frame on this and the percentage improvement in proprioception, but this opens up a whole new box where you can change performance within a session. And in this particular team too, from the captain down, a chap called Steve Gerard, you may have heard of him, he had all his problems on the left-hand side. From him down, 80% of the team had one-sided problems. Video. Everybody's got one. How many people have got a phone? And on that phone, you video everything. And I'm doing this with patients. Give me your phone. We're going to record it. But this is where having tests. So here's one of our footballers. One side versus the other. Is there an asymmetry? And this is what we're talking about. You've got an asymmetry index. One side doesn't work as well as the other. That side that doesn't work is generally, pretty often, would I say always, the side of the problems. There are a group of outliers, but this is the thing. We're going to have one side that we're going to manage and then reassess. The same patient on the same day, wearing the same undies, in the same room, doing the same test post-intervention. And do we have a change? Do we have a difference? Do we actually have better function on that right-hand side compared to the previous? So we can do this consistently and reliably. If we look here, here's his body chart. True story. Shoulder, hips, couple of ACLs and scopes, perineals, ankle, tear, hamstring, boom. How often have we seen this? If you deal in sports medicine, you'll see this all the time. And this is part of the problem. Most of his problems are on the right. These problems on the left, which were more recent, were secondary. Treating those wasn't working. Sort out his right side, they went away. So getting away from just treating these structures, especially in guys playing at this level, at this expense. So this is how it was managed. Exercises on the right, just into extension, would improve. If we did his unmatched bias, which was things on the left in flexion, his performance deteriorated. So here it is. So the directional bias icon, if you're doing clinical Pilates, this is what you should be hearing. You're hearing the fact that they're doing one side in one direction. 4 quadrants. And again, this has been done before. If you look at the McKenzie model, which has level 1 evidence, this is again based on that. Panjabi's model, this is Panjabi's model taken to include asymmetry as opposed to just flexion extension. We're not the only ones to look at this model. So we looked at this to say through Otago University, is it reliable? Does it have predictive validity? And looked at the jump measure, but this time including dynamic stability test that's been validated of time to stabilization. How high can you jump? What happens when you land? How quickly can you control the perturbation moment? Simple little study. A baseline test looking at time to stabilization, looking at AP and mediolateral, that's flexion extension left, right, and also hop, flight time, and land. So the first group, 4 exercises only. How little can we do to actually get some benefit from this? The predictor being doing the match bias, i.e. the correct exercises between baseline and retest. Would there be improvement? And there was. Same group, now doing the wrong exercises on purpose, unmatched bias, and the predictor was they'd deteriorate, and they did. Second group, baseline test, wrong things first, yep, they got worse. Right things second, yep, they got better. So it's a simple little 2x2 crossover study, and we're replicating this in a number of situations at the moment because it is simple. So flexion biased exercises on the right would look like this. And these would be exercises over here. He's got a right-sided problem and a preference for flexion. So this is a flexion position, and we just move the right leg only. This, a roll back, but off to the right. Sorry, did I say right? Yes. Off to the right side in flexion. This position here, standing on the machine, but off to the right in flexion. This position, off to the right in flexion. So those 4 exercises all match this criteria. We're not going to do both sides, and we're not going to incorporate extension. So how does this look if we start producing it with patients? Here's an example here, looking at simple tests. So pre-intervention, get the patient simple function tests. We're testing a number of structures with that, but between her left side and her right side, is there a difference? I guess you could say yes. And don't say weak glute. This is 2 years post-trauma. This is 2 years of treating that glute and all the rest of it. And she's currently lined up for hip surgery. Does she need that surgery? And again, more effort needed on that right side. One more test. Let's do a hop. And you won't be surprised that this is not going to look terribly flash. Okay, but based on her history, we're able to determine, we know the right side's the problem, so that takes the left side out of the equation. And we also found that flexion was an exclusion, leaving us right side problem needing extension exercises. They were then applied, and same patient, same day, same test, post-intervention. We've given the same test there, and we have that left side still looking about the same, but the right side, we're getting better function. So we haven't strengthened a muscle. This is the same day, same session, within subject and within session. The risers, up we go. We have an improvement of a little bit, but this noticeably better feed forward. So again, we're working well above strength here. We work on a different model. Finally, and the hop, better than the previous. So this is where recording outcomes becomes critical. Self-reporting is valid. So it's a functional, patient-specific function, looking at function of squat, rise, and hop. She scored herself out of 5, gave herself a 4, a 4, and a 3 on the left pre-intervention. It's about 73% function, but on the right side, 1.5, 2.5, 1, about 33. You wouldn't argue with that. Her function was much poorer. So we got a 40% asymmetry index. Post-intervention of just right extension exercise, we had about a 3% difference there. Not a huge change, not significant, but the fact we had a 37% improvement there, she scored herself much better on those post-intervention tests. That surgery is not necessary. These are not opinions. This is hard numbers. 37% improvement in function. If you set 10% as the threshold, that's enough to say this person doesn't need surgery. We've just saved $30,000. And this is reliable and replicable. So this is the exercise that made the difference. These meet that right extension bias. Legs to the right, just move the right leg. Don't do both legs. This exercise, which is very popular, I can tell you right now, if I find people doing this on both sides, I will track them down and I will torture them. One side. It's an excellent exercise, but it's used so badly because any benefit is negated by doing it on both sides. We can prove this. So you just move the problem leg in extension and don't give it to a flexion person. Extension, right side, knee stretch, also an extension, hands to the right. 4 exercises. They were the 4 exercises meeting the criteria that made the difference that was recordable of 37%. So what are we looking at? This is a post hoc analysis we also did through Otago University, looking at proprioceptive change. And that's one of the big ones these days, particularly in the world of sports medicine, because we know strength training, despite still being used and talked about widely, doesn't provide injury prevention. Why are so many athletes injured? They're strong. And we know, in fact, increasing strength and conditioning programs increases injury rates. This is a given. So we need something to take the place of this. Proprioception has been looked at, particularly things like ACLs. Strong guys with big legs just fall over, 80% non-contact. Proprioceptive deficit latency. So looking at this test, 6 tests here, single leg balance, elastic band, blah, blah, blah. Looking at these to say, right, how many weeks of this? 2, 4, 6 weeks, using what measure of proprioception and how much do they get? 13, 20, 8. Some getting worse, and we see this. Single leg hop to stability training, elastic band training. We're actually making people worse. Some doing quite nicely, but this is over a 6-week period. The Otago group came back using the one side, one direction model, found a 26.9% improvement within 16 minutes consistently. So this is the within session, within subject stuff. 2 to 4, 6 weeks. You could have many other variables that could have been attributed to that change. The 16 minutes, there are no other variables. They are all controlled. The subject has not left the room. So this has brought about a huge amount of interest. As I said, this one hasn't been published yet, but we have presented it in the Rugby World, the Rugby World Cup, the Premier League World, and it is making a lot of change to how ACLs are going to be managed. How we're looking at this at the moment is looking at exercise and treatment based on their history. We find, as we said before, the majority of injuries are asymmetrical. Now, you only need 4 points to make a decision, and we're finding the body chart being number one. We're finding also something that physios always ask is your ag factors and your easing factors. Every physio asks it. My aggravating factors of flexion, my aggravating factors of bending over, my aggravating factors, they're exclusions from treatment. Easing factors are extension, walking, going swimming. All of these things also need to be included in their thing. And trauma, we're finding direction trauma is to be a big one. The bending, twisting injury, we've heard about this time and time again. But these 4 factors will give you something to work on. You've got a right side, you've got a hamstring, you've got a tendinopathy, tendinalgia, that's the new name, tendinitis. That's a one-sided problem, not 4 different structures, 3 different structures playing up. If the easing factors are extension, walking, swimming, lying prone, that's an inclusion. So this will be a right extension. Aggravating factor of flexion, exclusion. A trauma, a flexion. I bent over to pick up the football, I tore my hamstring. That's a flexion trauma. Kicking a football, tore my hamstring. That's a flexion trauma. So this is where the simple model is there. It's called a heuristic. I won't go into it now. That's a 2-day lecture on itself called bias variance dilemma, but it's what's used in the military for rapid decision-making under pressure, same with airline pilots, and it's unfortunately not taught to medical students or physio students in university. How much information do you need to make a quick decision with high accuracy? You don't need a lot. We think the more information, the better. The more information, the more chronic and complex it becomes. So we can't control all risks, but we can make good judgments based on a small amount of information. It's knowing what that information is. So Steve Jobs used it. You've got to work clean, make it simple. That's how Apple became, and still is, the most profitable corporation on the planet. They gave very few choices in the first Macs. Not 50 variations, only 5. And less decisions to be made them quicker, made them a lot of money. So 10 years ago, we were asked to give in brief, quick things that are practical and sensitive for practice. That's been the problem. The Holy Grail was to match treatments to patients and the physical predictors. In 2010, we can now say we've done it. We've proven it. As I said, we've got a 0.87 kappa inter-rater reliability on this process, so we know it's robust. That has also been published through Otago University, and we can state we can break the rules. You've learned the rules, you know what the rules are. Now we can teach you how to break them. And not so much break the rules, but move beyond the current into the next level. How do we make this work? Don't get stuck. We go around and round in circles. You've got to know how to get straight to the situation, because time is precious. Time, you don't have a lot of time to sit there and stand there looking at all these scans. Yes, work out what's relevant, what's not. Find out and make sure that things haven't been missed. That is absolutely necessary. But here we have the process. So when you get out into looking at clinical Pilates, it is a treatment tool. Clinical exercise is not. But you can also apply evidence-based medicine factors to it on the background that's being researched. There's more research currently going on at the moment. And now post-COVID, we've got some more challenges to get onto, which we are taking to with great excitement. So thank you very much again. Thank you all the guys that are online. Great to see so much interest, and also for the guys that we'll send this clip to. You can follow up on this, and happy to take you, and hope we see you at some stage being involved in either research, training, all the above. talk soon, and I'll just finish this up now. There we are. We've done well. You're all hidden, yes. So there you go. All right. Thanks again, and look forward to being in touch not too far in the future.